Ready, okay. Good afternoon. Today is February the 12th, 2025, and it is 1 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Strategic Planning Committee. As a reminder, a committee member may also be participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. Our first agenda is public communications. We have no public communications for the Strategic Planning Committee today. So we will now proceed to the committee agenda. Number 1, receive a presentation from Integral Care and Central Health on the Diversion Steering Committee, including an Austin State Hospital update. Pat Lee, Ann Kitchen, and Jeff Richardson, Integral Care CEO, will be presenting.
We're going to hold hands through all of this.
Yeah, ready, Jeff?
To show our partnership.
We thought we might lace arms and sip the champagne flutes together. But seriously, it is truly an honor. Truly an honor to be here with Jeff. Both of us, I think, started in a relatively similar cohort, and I think we share this sense of optimism and collaboration, and a deep understanding of how intricately interwoven mental health and physical health, and access and quality, dignity and outcomes are. And so we're delighted to co-present, and we're just going to be tag teaming through this whole thing together. We'll aim to kind of go through relatively quickly, so there's room for some discussion. Next slide, please. We're going to talk about community planning efforts, high level. Then we'll talk about the Mental Health Diversion Steering Committee that Chair Kitchen and Jeff and I and others participated in with Travis County under Judge Brown's leadership. And then we'll talk about some ASH planning collaboration that we participated in under the mayor's leadership. And so with that, let me hand over to Jeff to get us started on community planning efforts.
Thank you, Pat. And again, I think everyone, in terms of, this is sort of describing what's been going on at both the city and the county level, but there's also a lot of strategic planning that we are doing with each other and continue to work on. And Integral Care is just about to embark in a 3-year strategic planning process as we speak. So this is a good time for us to start looking at all of this, to start thinking about not just what has happened, but how do we respond to the changing landscape we're in right now, and also be more strategic about how we move forward as a community. I think one of the things that Pat and I have talked a lot about is how do we coordinate our efforts and not overlap with each other and our partners, so that we all have a much more systemic, strategic way that we're delivering these vital services. So what really has been happening, and this happened soon after both I started and I know Pat started, a lot of energy to really look at a number of issues at the county and the city level. First off was this whole notion of the challenge, a lot of the imminent challenges that were happening. One, that there were a lot of folks in our community with very complex behavioral health needs. And I won't have to tell anyone in this room that means that a lot of cases, instead of available hospital beds where people could get treatment, people were getting arrested and caught in the jail system. People were going in and out of systems of care that were not necessarily meeting their goals and targets. There was difficulty getting people into state hospital beds when appropriate. There are folks that are in state hospital beds that have medical comorbidities that really is their preeminent challenge. And so there's a lot of things at once. And so, there's some very specific targets that we've talked about with the city and the county, but this isn't the end of it. This is just the tip of the iceberg in terms of the work that we have to do. But again, along with the challenges that we've listed here, which is people with a range of complex psychiatric needs, needing state hospital beds, and again, getting into the state hospital is almost impossible right now. And I know some of the work that we're doing is competency restoration work that we're contracting with hospitals outside of Travis County to continue that work. The co-occurring medical, physical concerns, crisis care, and again, the diversion center work was also looking for secure facilities, places to get people treatment outside of the hospital model. And so insufficient crisis care and long-term supports for people experiencing homelessness. One of the things that we've also seen is being able to create access and crisis residential services that were not at the level of hospitalization or crisis care and stepping people down. And the focus for a lot of the county work has been in really enhancing the diversion work that's already been done. And again, I want to thank this board for the support on the diversion pilot, which is going really well in terms of the number of folks that are utilizing it. It started slow and picked up very rapidly in terms of where it's going. But I think what we've identified is there's a group of folks that need much more intensive treatment with some pretty significant needs that we need that have been unaddressed in this community. Next slide, please. So the planning efforts that we're talking about today, really there was sort of two parallel universes. One was the work that we have been doing with Central Health and with the city to really look at how we could develop a continuum of residential and medical supports for folks with severe mental health needs and significant comorbid medical needs. The other is really the work that the Diversion Center Committee, and again, Ann's been involved in those discussions as well, considering and focused on the diversion piece of the work. So we've had two sort of, not parallel, but concurrent efforts going on with the city really looking at the housing piece of this work and the county really looking at the diversion work. And I think both Pat and I early on were encouraging all of our partners to remind that one is not excluded the other, and this is really a bigger discussion around our ecosystem that we're in. There's a lot of things that make a healthy behavioral health system of care work, and we need everything at a certain scale and scope.
Yeah, and then just building on some of Jeff's comments here, just underlining the importance of collaboration. It would be possible for our agencies to be in conflict or step to his toes. It'd be possible for the efforts going through the community to feel duplicative or disconnected. And I think beginning with us and then with our teams, as we've shared with the board before, we spent a lot of time with each other, visiting together, envisioning together. I think we've improved empathy, respect, communication, and we've moved some important co-visioning work together, as we'll talk about later on in this presentation, in the Ash Campus vision. I'll also remind our board, as we talked about before, that we were trying to create a common sense of what the intersection between physical and mental health looks like. A 2x2 graph that Jeff brought to our joint teams in this room a little while back, where you imagine the acuity of physical health on one axis, the acuity of mental health on the other axis, and patients moving between these areas over the course of their journey. And how do we blend those services together and acknowledge a patient's preference and where they'd want to get their care? And so we're continuing to iterate toward that shared vision so that what we unite around is what we're trying to accomplish while we manage any differences across agencies. And I think the same intent is true as we work to navigate and really merge and align. Lots of great work led by the judge and the mayor and others.
So it's getting everybody to play on the field in the right positions so we can coordinate our efforts rather than fall over each other. And that's where a lot of the heavy lifting is going to happen when we talk about strategy, is how do we determine, how do we support the city and the county's focus, how do we coordinate all the other partners involved in this work and make the resources at the most efficient, least restrictive way possible available. So if you go to the next slide. The two kind of parallel efforts that have been going on. One has been about the Travis County Mental Health Diversion Steering Committee, and I mentioned that a little bit earlier. And I know Pat and I I know there had been meetings going on for some time before both of us got here around the diversion center and the importance of the sheer number of people in the jails who have some significant mental health needs. And the statistics go anywhere from 40% to about 80% of the folks in the jail struggling with some severe chronic mental illness. And, so part of the work was really how do we help people who don't need to be in jail get the treatment that they need and create a way to divert and deflect people from actually ending up in jail if they don't need to be there. And a simple formula for that is actually providing treatment for folks rather than arresting them for it. And so part of the work that we've been doing is with the criminal justice partners, with the county, to really look at ways to continue to expand on the work that we've already been doing in the community as partners around diversion, deflection, the MCOT work that we've been doing, the 988 and 911's focus. There's so many touch points in our system that we looked at. But for this, there was a real focus towards targeting some key areas. And if you go to the next slide, the diversion steering committee really came to some clear decision making around what the most important targeted areas that we needed to tackle with this. Again, we couldn't solve the entire ecosystem with the diversion center steering committee, but really focus on a couple areas that were really important, which is some of the people that are entering the jail system who are return visitors. And the reason they're there is not exclusively because of a criminal rationale. It's because of pretty significant behavioral health, chronic, untreated mental health needs. And at an acute phase, meaning they're presenting with very active symptoms that have been untreated and not really evaluated at a scope and scale that they need to be. And I'll remind folks that we do have residential crisis programs. We have a PES, an psychiatric evaluation service, and thanks to Central Health, has allowed us to make it 24/7 so that people can be dropped off and evaluated 24/7, which is something that just recently this year was added and had a huge bonus to that work. But what's been identified is there's a group of folks in our community that a voluntary residential diversion center is not sufficient, meaning they need additional treatment and additional time in a facility. And so, a couple of us had light bulbs that popped over our heads that said, gee, that kind of facility, that's a hospital, isn't it? And that's where people can actually get treatment and get the kind of treatment that they need to be able to stabilize so they don't have to continue to return to the jail and to the streets. Next slide, please. So the committee really came up with essentially three elements that we wanted to build out and build as key assumptions out of this work. Number one was what I just mentioned, really to look at a public psychiatric hospital, meaning one that was available for this population and hopefully others over time, to be able to target voluntary and involuntary commitments, again, so that people could get care not for being arrested, but actually for clinical reasons, and get the treatment that they need to actually manage symptoms and help them move on to a successful contributors to our community and link them to other parts of our behavioral health continuum. The other really important part of this is that also including stabilization beds for greater than 30 days, so that there are some people that really need to be in the hospital and long-term care longer. And for that reason, so to evaluate clinically their needs, to evaluate some of the things that we're doing in other levels of continuum, ensuring that they have access to housing, support services, so this cycle does not continue. But most importantly there is being able to provide treatment to people and not be on this is a very focused group of people who need supports that may not otherwise be served in a for-profit hospital or an ED and ER, meaning this focuses very much on people with long-term chronic untreated mental health needs. So that whole component would be really critical to doing this, because I know this diversion committee really looked for a while is how do we create a mechanism to contain people who need treatment who've been arrested. And again, that is a hospital, and that's what we really wanted to focus in on. The second component was really the new development of a central booking and intake facility for folks who were getting arrested. And so that point of booking and intake would allow people at that point to be not just evaluated for their whatever reason got them arrested, but also doing the psychiatric evaluation on the spot, and having hopefully at that site also availability of observation beds to be able to look at triage and evaluation before we refer the folks to another part of our system. So again, in hopes to be able to give the right kind of treatment at the right point and the right time. And again, this only works if there's dedicated space for not just the treatment, but for the legal and navigational supports that somebody needs. So that may be another point of entry in our system that we can deflect or get people to the right level of care. And then the third piece of that was really looking at our PES service, which is our psychiatric evaluation service. And if I throw any acronyms out that you don't know, you're welcome to throw your cookie at me. I know we use those a lot in this space, but PES is the psychiatric evaluation service where we have clinicians, psychiatrists, nurse practitioners evaluating, starting treatment people as needed, and that's where folks from both police, EMS, and people can walk in to get evaluations, and at a point to triage people into other levels of care. So, and then with that would also be important to accept 100% of the drop-offs, meaning being, regardless of someone's medical condition or their psychiatric condition, the ability to both have our police partners and EMS partners working very closely with this, and being able to ensure that everyone who shows up, we're able to handle and manage and enter them into the right part of our system. And again, this is a very therapeutic environment focused on de-escalation and then targeting also criminal justice services. And the exciting work about all of this is the work that Pat mentioned, is how do we ensure that we address the intersection of that primary health needs with the behavioral health, and at what level and at what intensity. Next slide.
If I may?
Yes, please.
I'm sorry to interrupt you. About the drop-off, part of these patients are extremely complicated medically. Do you envision having a medical team, not just to see if they're having a psychotic crisis, but if they perhaps have some other medical issue going on? Would that be incorporated into that setting, do you think?
That's what we're hoping for, because I think that part of the work that we also want to present is that the reason for either their psychosis or their challenges may not be the behavioral health needs. It may be a medical condition or an untreated one that this may not be the best solution either.
I mean, currently, Shoal Creek won't accept someone until they're medically cleared completely.
Yes.
So that'd be great to consider. The other thing about, when you say treatment, to what scope of extent do you mean? Things, electroconvulsive therapy, things like that?
You're talking about in the hospital?
In the hospital.
I think one of the things that we're excited about, and I don't want to prescribe how that's going to look, but some of you guys know I worked in a large hospital system, a psychiatric hospital system, before I got here. Not every patient who's presenting into the system needs the same kind of treatment. Not everyone's showing up. We want to be able to provide substance use treatment. We want to provide a level of treatment that we haven't been able to do otherwise in some of our short-term hospitalizations. I would love to see that as an option, along with a lot of other things that are more imminent, and also have some subspecialties in terms of clinical supports. We're looking at folks with addictionologists on staff, folks looking at with very good experience looking at psychotropic medication management and being able to try people on long-term injectables, which is a piece that there's a lot of evidence to how successful, as long as we can do that in the right way and get people involved early in that process.
Yeah. And just building on this, Dr. Martin, I think this is part of the benefit of us being tightly engaged. So what does that medical clearance look like in triage at the front door? If we're preparing for electroconvulsive therapy, are we doing appropriate cardiac clearance and so on? So how do we weave that all seamlessly together and plan at every stage? Really glad to be in the conversation together side by side. And I'd just take a moment to brag about Jeff for a little bit. I think the experience you bring from Sheppard Pratt and from Baltimore and from your previous work has helped infuse this conversation with a lot of relevant comparative examples. And just the dynamic in that steering committee room, I think, was really enhanced by your presence.
Thank you very much.
Yeah, but I do think one of the issues that's going to make this successful is depending on what scale we can do it at. If it's really small, it's going to be hard to wrap that level of specialty around this. I mean, one of the conversations we've also had is with our DelMed partners as well, being able to recruit and have partners who are specialists that we can tie into being involved in this process. But the larger we could make this, the more precise we can be around the kind of treatment people get in that.
And perhaps this is too much into the weeds, but what is the status currently in terms of long-term injections, voluntarily and involuntarily? Is that an issue in California with that? I mean, I'm a big proponent of it, but.
Yeah, I mean, I think I can't speak to the Texas law on it now, but what I do there's some good movement on the FDA level in terms of allowing for less lab work needed for some of the long-term injectables that have particularly shown great progress. I don't know yet. I can't give you a good informed answer. But that's one of the things that this group has been great about, along with Pat and I being there, and of course Ann being there. We also have lawyers there that we're trying to challenge them about what we can do and what we can't do. There's other things, parts of our system that we also want to really look to refine, things like assisted outpatient treatment, how we can make that much more a tool that has a little bit more teeth to it, so people who are involved in that can get the kind of treatment that they need and not simply do this entirely on a voluntary basis. So a lot of work legally on this.
So let's take you through the ASH planning component so that we can then open a bit. Next slide, please. And go ahead, go to the next slide. Great. So this is really a nice segue from much of the very important sort of workflow work that Jeff was talking through. If we come up a level and think about the continuum of care, the essential point here is that you see at the base of this visual, the Austin State Hospital, a beautiful state-of-the-art 240-bed hospital. But the key insight I wanted to share with the board is that there had always been a plan that there would be a continuum of care downstream of that hospital. So think of that hospital as like an intensive care unit for brain health. When you need it, you absolutely need it. But then as you stabilize and recover, there should be a place for you to go as you move back into the equivalent of inpatient care and then skilled nursing facility level care, and then sort of specialized outpatient care, and then the right ongoing, outpatient care with an integrated physical and behavioral health team. And there is a very important part of this that reflects the diversion deflection work we've just gone into in depth. So what we see here represented in the pink and the blue and the black are elements that with Mayor Watson's lead, Jeff and our teams really collaborated to build out and extend from the work that the Strakowski-Delmet report had done earlier, and sort of articulate very consistent with what that vision was, and also link into the concept of diversion. You see on the right-hand side, some of the elements of an ideal system include case management, peer navigation, seamless transitions, guardianship and competency restoration services, medical screening and triage, trauma-informed therapeutic environments, a sort of campus feel, and substance use disorder capacity. Next slide, please. So at a high level, what we did at a very high level was a costing exercise to take some of the data that we had, that Integral Care had, that we had at benchmarks, and say, well, how would we accommodate the volume that we think we know about from the Strakowski report or from current state Austin State Hospital census numbers, recognizing that that's not perfect. We wanted to get something on a page that was directionally correct. So what about 100 beds of skilled nursing for the ASH volume? As an aside, I'll mention this is likely a statewide issue, that there isn't enough continuum of care downstream of the state hospitals across the state. But this is sized just for the Austin State Hospital component. What about behavioral health respite? These come in 16-bed units because of compliance and regulations to 2 of those that Integral Care would operate. Therapeutic residential, so the right kind of care in a more residential setting, but tailored for these patients. 3 of those 16-bed units operate Integral Care. This is not necessarily exactly what we would need, but proportionally, directionally, we felt pretty comfortable with this. And just at a high level, we broadly estimated that this would take about $120 million in today's dollars to build it, and about $56 million on a rolling basis to operate it. As a key nuance, as this board is aware, Travis County taxpayer dollars can only be used to care for Travis County residents, and there are many non-Travis County residents who would fall in this category, so appropriate operating sources would of course have to be thought about. And so that $17 million is a very rough estimate of what we thought in a future state like this we could cover for Travis County residents. And there's a small component Medicaid supplemental payments, the so-called QIP payments, that would come in relatively small, $3-4 million a year or something like that, which we factored in there. So there would be an operating need ongoing. Next page, please.
And Pat, if I could just add
Please.
to this, one of the things that was on that visual that we had also is a hub in the middle, which would be both medical and behavioral health treatment services that would be coordinated and wrapping around all these services. Because two things we really thought a lot about, which is how do we ensure that there's coordination between levels of care? As you guys know, that when someone moves from a hospital to the community to another program, people have to endure a whole nother level of torment about their information, dealing with a new treatment team. And we wanted to try and build a continuum and a team supporting people within that whole ecosystem. The other point really is important, which is this is not just some new thing we're doing. It relieves the entire system. And that was part of the work that we've tried to promote with the mayor and actually the state conversations, which is if we do this well, and I know you're going to go over this in this slide, but it relieves an enormous amount of pressure and opens up those beds at the state hospital for people who really need that level of clinical care.
Yeah, so perfect segue. And actually, just underlining Jeff's point that if we have those teams adjacent to all those services, there's an operational efficiency component to that, as well as a coordination of care component. The same people will be working together to care for the same patients who are moving across these levels without the need to travel back and forth all over the city. So there's a lot of benefit there. So just at a high level, walking through some of the savings and benefits that we calculated, a lot of this was really based on the notion that we know there are about 85 people current state out of those 240 beds who do not need that ICU level of brain health care. Their needs are lower than that. They might, at this point, after a traumatic brain injury, for example, have significant physical health needs, nursing needs, wound care, tube feeds, those kind of things, but their behavioral or brain health need is stabilized. They don't need to be in that intensive care setting. So we know from the data that there are about 85 people who have been residing at ASH for between 1 and 11 years. If those 85 beds were not needed to house those people, we estimate each of those beds could probably take care of a little over 2, maybe 3 people a year. So conservatively, maybe 200 more patients could get that ICU level of care. And then again, making some broad assumptions, a number of the folks who need that care are also experiencing homelessness. So we just used a broad estimate of 50%. It might be a little more, it might be a little less, but it is a significant number. And so that's about 100 people a year who potentially could get the mental health care they need rather than be homeless on the streets.
And and Pat, the other part of that we talked a lot about, which was if somebody moves through those levels of care, having, for example, residential crisis services, people do not have to go back to the hospital. So what it does is it provides a step down and a step up to prevent needless admissions that then further get people trapped into that process that we around available beds, moving folks successfully to the community.
Yep, that's right. And so just walking through the assumptions here, so that $29.6 million, that's the difference between what it costs to care for people at ASH and the highest level of services and what it would cost to care for them at a skilled nursing facility level or intensive therapeutic residential level and so on, whatever the per bed day cost at those lower levels would be appropriate to their needs. We took that difference, rolls up to about $30 million in year one, and that it inflates year over year in our estimates. There's also avoided emergency services costs, about $16 million, and costs that we were not able to quantify, but when patients are not able to get into ASH, but they need that level of services, the state actually has an obligation, and those patients receive beds that are available in regional psychiatric facilities that actually use up that capacity and create bottlenecks and lack of access all across the state. And so by relieving the bottleneck at ASH, we potentially relieve and improve access across the board. And so we didn't have a way to quantify that, but the benefits there accrue to the state and are north of what we described here. But with the numbers we did had, we asked how long would it take, given the one-time build costs and the ongoing operating costs, minus the savings, to have the savings surpass the overall build costs. That was about 5 years. And if you roll forward over 30 years at these estimates, I think we conservatively estimate that about $2 billion would be saved. This is just in the per bed day cost of care. I think the overall impact would be broader than that. And these assume a 5% annual inflation and about 3,000 patients over the course of 30 years avoiding homelessness. So again, these are imprecise, but I think directionally correct estimates to give us a sense of the scope of the benefit of what is a significant but relatively modest investment up front for a relatively large potential benefit in health and economic savings and doing the right thing.
And just tying what Pat said earlier about just as the local mental health authority, we're also funding competency restoration beds outside of the county, funding county residents to be in for-profit hospital entities outside of this county to get those services. And they're not coordinated with all of this other ecosystem of services. So much will be freed up if we're able to start, if we can't do all this day one, progressively doing this is going to relieve important parts of that work. And those folks, I think, would be better served in a full ecosystem that we just described. So the money's being spent. It's not all being spent here in Travis County.
It's just a final acknowledgement of the leadership of the judge and the mayor and so many stakeholders in our area for convening the conversation. We're on to be part of it, and really our role is to kind of describe from our experience what we think might work from a health and health system integration perspective. And so with that, I think we'd love to open up for any comments or questions. And Chair Kitchen, did you want to share any additional? Okay, please.
I just wanted to say we expect to complete this task by next week. So stay tuned.
All right, so I want everybody to think very carefully, because we're just going to go around the room once, okay? So any questions anybody may have, and let's start with Cynthia.
You mean Dr. Zamora?
Oh, Dr. Zamora. No questions.
You said that with such concern.
Well, the adult population didn't just appear in Travis County. It's grown from our kids that are not taken care of in the school system, 17 school districts in this area. Many of which have behavioral BIPs, they have behavioral intervention plans that are not followed, that are not even written up because we have poor diagnosticians in the school systems. Parents are unable to care or provide. There may be an older brother or grandmother or somebody that's taken care of. So the households, the families are at great stress to provide for these kids who end up in the street, dropping out between middle school and high school, or between high school and alleged adulthood. That's, to me, these kids are already adults by the time they hit middle school. So my question is, what are we doing? Because you at Integral Care are fully aware of who they are in the school systems. Most of them are patients of y'all's, Integral Care, if I'm not mistaken. And like my daughter, who's been in the system forever, and she's 33 now. But there are many more that have dropped through the school's cracks. And so those, I think, are a lot of the people that we're dealing with and we're talking about. Is there a way to see whether or not they're actually being transitioned well, that they're being taken care of in their younger eras and then transitioned into adulthood? Because if it's a special ed child that's deemed so, or 504 child because of behavioral issues, they're no longer going to be in the school system when they graduate, and they can graduate up to 22 depending on how the parent chooses to educate them. The issue is they're going to be stressed. They're not transitioned well, and if they're not transitioned well, that's who you're dealing with. And as things are changing right now economically for households, I think you're going to find more and more people that are unable to provide for these kids, and they're going to end up being, they're adults and children in the street. How are you going to handle those?
Yeah, Cynthia, that's a long question that I can't answer in one short sentence.
I know.
And then I'm happy to come back and talk more specifically about what we're doing now and what we expect to do with children's and transition age youth, which is what you're talking about as well.
I'm calling them children because but even if they're adults, they're still children.
I think there's some noteworthy things to highlight, but I'm happy to come back and talk more in depth about this. There are some programs that have shown a lot of clinical success if we can get the resources to scale them out. Example of which is one that has national research behind it that we're doing here at Integral Care here in Austin. We have a RAISE program, which is early intervention programs to prevent, and those have shown so much evidence of success if we intervene and wrap a team around someone at that age. That really changes the arc of the needs that you've just described. And these are programs that have shown success not just here but nationally. These are grant funded and they're narrowly funded in a way that we need to do more to
Are
support.
they going to disappear
Well, let's hope they don't,
under Doge?
because I think right now this is one that shows great success. Our big challenge here in the county is how do we scale things to the right set of needs. If we see, and so that's some of the work that I think Pat described earlier, that when we get into the weeds more about how do we elevate the right services at the right place, and how do we coordinate how our systems of care make those decisions, I think we can do that better. I do think the other thing that we have to keep in mind, on to your point earlier about Medicaid and what may or may not be happening at the federal or state level with that, because that will have a really harmful effect on our ability to serve children. So I'll stop there, but I'm happy to come back and talk more about kids.
Then just one last thing, because I'd like for you to make sure that you're working with your judges, not only in the courts, but in the municipal judges all across the board, because they're seeing these kids. I've sat in for days and nights and witnessed the lack of intervention by a competent adult on behalf of these kids that are adult age, yet clearly incompetent or not competent, and yet the judges have the responsibility of checking to see if they're special ed or if they have things, but most of them don't. So anyway,
Okay, thank you.
So just a plug for, this is a simple plug that we've been doing, which is we've talked a lot about mental health first aid. And one of the areas that we've seen a great uptick is with county, particularly youth mental health first aid, and any promotional work you can do to help us get that word out. We just did a full training of folks at the county. And again, the more awareness we can do, even at that level, really goes a long way.
Thank
So
you.
thank you.
All right, and Chair Kitchen?
Yeah, I just two things to try to help get us back on time. Great work. I just want to say thank you to both of you. This is very exciting, and I'm particularly excited about the bigger picture planning around ASH, and then the diversion center work is very concrete and it's happening. So thank y'all very much.
Thank you. I'd like to echo Chair Kitchen's words. It's long overdue. I have a question, sort of, or maybe a comment. Has consideration been made at all into sort of making this into a psychiatric center of excellence that would then draw funded patients that would help some of the cost, Robin Hood it to some extent? Has that been considered a private-public relationship?
It sure is, and I think one of the things we've been talking to both Dell about it has been looking at ways that we could attract some, particularly specialists in areas that if we were able to have the right set of market pressures to be able to afford to do this, that we could both serve both public and private folks to subsidize specialty care. This has also come up. I'll give you an example. We've right now been looking particularly at folks, adults with autism, and them getting stuck and not having specialty supports.
Yeah, I say that as a primary care doctor. There's a paucity of access to care for funded patients to get them in, to get ketamine, to get them ECT, to get them just acute management. And I think I just think that if we thought with that idea of a center of excellence, it might be a cost offset. Thank you.
And just build one more step on that, Dr. Martin. To my knowledge, and correct me if I'm wrong, Jeff, but a continuum of care like this doesn't exist in our country on a public facility like ASH. This could be the first in the country to do that and demonstrate what is possible as the state and UT and Integral Care and Central Health and ASH all collaborate with county and city really to create a model like that. And so there is a potential not only for the discovery and the research and the care, but even the collaboration that launches something like this to be an important step forward, I think, for the overall movement. So it's a really important thought, Dr. Martin. I hope there would be people, maybe even listening to this, who would think, if what we need is a modest amount of capital to get this moving, maybe we can help.
I do think your point about clinical precision in terms of the kind of treatment people need and being able to draw those more resources into this is really, really important. And to Pat's point, there are private systems that have done this. I don't want to say any more about my previous employer, but they did it, and they did it partly on a model where they attracted a lot of folks very interested in specialty care, but with braided funding, both public and private dollars. And we could certainly replicate that here.
Yes, Manager Jones.
Thanks very much. I think this has been very helpful, enlightening, and detailed. I have just a couple of comments and questions. One is, are we talking about, I heard several facilities being used in this structure. So are these facilities we're going to be building or we'll have to build, or are there facility that's currently exists or we will share in?
Probably the answer generally is yes to both using current facilities and looking to design very specialized facilities. Pat talked a little bit about the SNF. That would, in particular, we would need to have a really well-designed space to be able to do that doesn't currently exist on the campus. Some of the housing, some of the current buildings we may be able to retrofit, but again, when you start getting into costs of building versus using what's there, we're gonna look carefully about that. I mean, if this goes the direction we think, there may be buildings that exist there that we can use to get some of this started quickly, but also look at a much better designed facility that we could build. And as you saw in the earlier slide, there was definitely costs around new construction in that discussion. Did I miss something?
I think that's right. I mean, we would need to get in there and do the due diligence, understand to what degree are there issues of asbestos, ligature risk, and so on, things that prevent our ability to dig in the ground without new assessments and so on. And in the end, what we have heard is that the cost of deep renovation and new ground construction come pretty close, where at that point it may be worth the delta to build it new, build it to the most current standards to last for longer. So some of that we just don't know the answers to yet, Manager Jones.
The question is getting something going quickly versus waiting for to build it is always, and I would love to have some momentum to do something sooner than later.
Okay, I know I don't have time for another question, but I would just be interested in, is there any place else in the state considering doing something like this?
There are elements of this in different parts of the state. Lubbock, for example, has a small hospital attached to a diversion center that they're building. There are other providers doing little pieces of this in different ways that match a local community's needs. I think we have the advantage of having central health and integral care working hand in hand, and an existing set of continuum that I don't think really has existed at this scope or scale anywhere else in the state, and not at the way that we're talking about this. But there are pieces, and we're going to learn from those.
Thank you, Manager Jones. Manager May?
Thank you. I have a couple of questions, but I think that they're going to be more like you can come back and answer them later. First of all, I think this is wonderful what we're doing. The timing is right. It's about time we got this far. I think even the timing from a state level is possibly in the right place. I especially like Dr. Martin's comment about making a psychiatric center of excellence. I think that's a wonderful idea and possibly could get us in a place for funding and stuff. More importantly for me, and this is going to be possibly questions that you can come back and answer later, I'm interested in the demographics of whom we're going to serve. I'd like to know the age, the ethnicity, the race, as well as the presenting problems, if we can drill down to that. The second part of what I've asked for in terms of information is, and maybe by then we'll be in a better place too, because we'll be, a little further into the session. And that's probably gonna be a question that's gonna go back to perilous staff. And that is, I'd like some follow-up on the dollars that the state is looking to fund for similar programs or for such programs that begin to deal with psychiatric care and homelessness.
Okay, well, I mean, one of the things we can certainly look at is the data on the folks that we've targeted in the state hospital around demographics and clinical need. And we already have some of that data and we could share that.
Yeah, and for the second, I think we can provide an update to that targeted question. I believe there are a number of interesting ideas moving through legislature, so we'll take that as a follow-up, and
Yeah, and if
Pearl and
this
her
is
team.
becoming part of the work that you're doing now, I think it fits in her bailiwick.
Yes, agreed.
Thank you.
This may be a good moment, to your point, hopefully.
Thanks. Thank you all very
All right.
much.
Oh, great, thank you.
Great job.
Thank you. All right, there is, of course, no motion is needed on this item. And I have announced that the committee is convening in closed session to discuss agenda item number 2 under Texas Government Code 551.071, consultation with attorney, and under Texas Government Code 551.085, governing board of certain providers of healthcare services, and agenda item number 3 under the Texas Government Code 551.071, consultation with attorney. And it is 1:46 p.m. Oh, I'm sorry. Okay. To item number 2, receive and discuss an update on Central Health's enrollment into Medicare and Medicaid. And item number 3, confirm the next receive an update from council and discuss the impact of certain state and federal policies. Okay, it is now 1:47 p.m. It is February the 12th, 2025, and it is 2:22 p.m., and we are moving into open session. So, number 2, receive and discuss an update on Central Health enrollment into Medicare and Medicaid program. No, not that one. Okay. Okay. All right. Confirm the next strategic planning committee meeting date, time, and location. Our next Central Health Strategic Planning Committee meeting is tentatively scheduled on Wednesday, March the 12th, 2025 at 1 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I'm ready to accept a motion for adjournment.
So moved.
Yes, and a second? Second on from Eliza May. And all in agreement? Aye. 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 Any disagreement or, no? No, okay. All right, thank you very much.
Good afternoon. Today is February 12th, 2025, and it is 2:24 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Ad Hoc Appointments Committee. As a reminder, some of our committee members may also be participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. We'll now proceed to the committee agenda. At this time, I'd just like to announce that the committee is convening in closed session to discuss agenda item 1 under the Texas Governance Code 551.074, personal matters. The item here.
Yeah.
The item being review applications submitted for the Community Care Health Center's Board of Directors and take appropriate action to select candidates be interviewed on February 17th, 2025. out of closed session, and it is 2:41 on February 12th, 2025. At this time, I'd like to ask for a motion. Ms. Brinson?
I move that the committee select the following candidates to be interviewed on February 17th, 2025. That will be Diana.
No.
Oh, thank you. Okay.
As discussed.
As discussed in the, as discussed.
Do I have a second? Thank you. I have any, I'm sorry. Vote yeas?
Yay.
Abstention? Yeas? No. Yeas, 3, abstention 1. So the motion passes. The next agenda is to confirm the next regular ad hoc appointments committee, meeting date, time, and location. Manager of the next Central Health ad hoc appointments committee is tentatively scheduled for Monday, February 17th at 10 a.m. at the Central Health headquarters. At this time, I'm ready to accept the motion for adjournment. Okay, first, second by Ms. Brinson. Thank you. We're adjourned.
Okay, thank you. Good afternoon. Today is February 12th, and it is 2:42. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. Do we have any public communication? Okay, no public communication. So we will go on to the we'll now proceed to the consent agenda. I'm looking for a motion on the consent agenda. Consent agenda item number 1, which is to approve the reappointment of Ms. Sadora Jefferson as recommended by the Ad hoc Appointments Committee. A motion by Manager Valadez, seconded by Manager Brinson. All in favor? Aye. Anyone opposed? Okay, one opposed. Any abstentions? No. One abstention. Okay. All right, we'll now proceed to so the motion passes. We'll now proceed to the regular agenda. Let's see. Item number 1 is to discuss and take appropriate action on the performance of the Central Health President and CEO, including activities and performance criteria for the upcoming year. And item number 2 is to receive an update on proposed amendments to the Central Health financial policies as delegated by Travis County Commissioners Court. So I announce that the board is convening in closed session to discuss agenda item number 1 under Texas Government Code Section 551.074 personnel matters and Texas Government Code Section 551.071 consultation with attorney. And then agenda item number 2 under Texas Government Code Section 551.071 consultation with attorney. So we're going to go into closed session now at 2:43, February 12th. 3, and we're entering open session. We're taking up item number 3, which is to receive an update on action items related to the board retreat discussions on long-term planning for the Travis County Hospital District. So members, this is about, just for our staff and team to let us know where they're at in terms of the next steps on the items that we all identified together at the retreat. And these were, this is all open session, so we're doing it in open session. So anyway, go ahead and tell us where you're at.
And even though we're in open session, we're providing a high-level update on some of the things that came out of the second part of the retreat that was in closed session, and that is just that we, in the immediate to near term, we're working to provide the board with confidential briefings regarding areas of assessment of financial risks, gap areas, key decisions that we're going to be bringing to you that need to be made, and strategies including developing a strategy to communicate with and gain support from the community around the central health planning that we discussed in the second part of the meeting. And also we will be bringing a timeline or timelines for phasing and staging the work to be done, and recommendations around prioritizing that work to you over the next couple of board and strategic planning committee meetings to get your feedback on that.
And then there were several other follow-up items related to follow-up retreats and meetings. You'll see here the list. I'm not going to go through everything, but you'll see that we talked about having some follow-up retreats, at least 2 or more conversations, so we'll be bringing that back on the timeline.
And we started sharing some of the information about other hospital districts and lessons learned yesterday. You all will get a copy of The People's Hospital, which is kind of a book about Harris Health and the policy implications, and particularly for healthcare, safety net healthcare in Texas. And also there was an article that we sent out yesterday around clinics and community hospital expansions that are happening currently in San Antonio.
We're discussing with our Travis County attorneys how we might coordinate a tour of some other hospital districts to learn their models and perhaps have some conversation with some of the leaders at those districts. And then we also have on the agenda to plan some conversations with community care, integral care for alignment and focus on the mission. And yes, before budget season. This is
Yeah, it's a long,
This
so
is
we've
a
got
lot
things
that
in
we're
the
working on.
immediate term, kind of this month and next month, and then in the next 30 and 60 days, and then going out after that into the next 9 months. You know, you guys, I think, had some strong visions around also meeting with the city, the county, other nonprofit boards that provide social services, potentially in community-based organizations, so that we could align strategic plans and they could understand what our planning efforts are and we could understand theirs as well.
We also some discussions with staff and CEO just to delineate roles and expectations. Down the list, you also see what we heard from you was having some listening sessions with the neighborhood associations and community conversations. We have some planned already, and so we're discussing how we might be able to integrate some of these conversations into those existing community conversations. And then we also have a few items for 60 days and next 9 months to a year. Within the next 60 days, we want to meet with city, county, state elected officials, including county commissioners, to begin to discuss their vision for the county's future, and especially around homelessness initiatives, which are a priority for us all. And then having some regional, further down, having some regional roundtable discussions, including Hayes, Bastrop County.
And then ultimately, after we've kind of assimilated and accumulated all this knowledge about, peers, other organizations, other public entities, and Central Health's vision, to come back at some later date and consider a strategy or exploration of rewriting Central Health's vision and mission statement to match what the vision and mission discussed are after, this 9 months to a year worth of information gathered.
Thank y'all. So this is sort of the first step. It's the list that came out of all of our conversations at the retreat. So y'all take a look at it. If you feel like we missed something, let us know. But this is intended to capture what we all wrote up on the board at the retreat. As you can see, there's a lot, and I think we saw that at the time. And so the challenge for Dr. Lee and our team here is getting this on a calendar. So we don't envy you that task, because you'll have to integrate these things, with our budget process and everything else that you're doing. So we understand, we want to be, I'll just speak for myself. These are all very important things, and I was really excited with what came out of the retreat, because I think these kinds of items gave us a real path forward to learn and think about how we want to grow. So I'm hoping that we can, but I also understand that we have to be realistic about the time that it's going to take to get these set. So I would just ask you to set them as expeditiously as possible. Do it. I know y'all will do this. Do it. Just get your calendar out for the, and see where you can put them, and we will be as flexible as we possibly can be to help you in getting these things set up. So, does anybody have any questions or comments they want to make?
I have a comment.
Go ahead.
In terms of getting the county and state officials, et cetera, I haven't heard, have we discussed strategic alignment with UT's goal?
No, we didn't do that.
That'd be one of the partners.
I think to have them beat our drum would be a good idea if we're on the same page.
Okay.
It should be here.
Would you envision that as some kind of meeting with UT, or do you have a thought on how?
Yeah, I think that, I think it'd be great. I mean,
Okay.
I think that to have them, I don't know the relationship with the county, but
Here.
this whole thing with affiliation agreement, I think there's a large amount of misunderstanding about what UT is actually doing for us. And I think that would help clarify them when they've come and given us presentations. It's been clarifying to a large extent to people who don't really understand the healthcare system. And I think to have maybe the county commissioners, they're juggling a lot of balls, to have a better view of the alignment we all have together, and the work they're doing might calm things down a little bit.
Yeah.
Okay.
Just my thoughts.
Any other thoughts or questions? Go ahead, Shannon.
And keeping in mind is that we're talking about a year in this process. Some of us may not be here in a year in terms of a time frame, and commissioners as well. So I'm just saying is that as we look at prioritizing these, we might want to think of, okay, are there things that we can do that would be synergistic to almost anyone come in versus this is something he or she particularly cares for.
Okay.
That's something you might want to consider as you prioritize your listing.
Okay. I think these are kind of roughly in priority order, not hard and fast priority, but they're kind of roughly the kinds of things we were thinking we needed to get done, for example, visiting other health systems high up on the list, because we talked about how important that was. The visiting with CUC and Integral Care, that's high up on the list, because that was important. At the very top of the list is what we talked about in terms of those, assessments. So yeah, but that's a point well taken, so. Yes,
Very quickly, I'd like for us, after we have done some preliminary work with our commissioners or having visited another healthcare district or hospital district, to get back to maybe round 2 or 3
okay,
of a retreat.
yes.
And to have that concentrate specifically on what that vision, that last part of the retreat
Yeah.
encompassed,
Yeah,
so that we can put it all on the table. I don't think we had any time to do that. And we were
we
acting.
just got started,
Yeah, we just got started, so I'd like for us to look at that, because there may be a reason for making sure that we need to either reprioritize or renumber what we do when.
Okay. Okay. Well, thank y'all very much. We will proceed. Okay, I'm going to move us now to the last item on our agenda, which I believe is somewhere. Okay. All right, the last item on our agenda is to confirm the next regular board meeting date, time, and location. Managers, our next Central Health Board of Managers meeting is scheduled for Wednesday, February 26th at 4 o'clock here at the Central Health headquarters. At this time, I'm ready to accept a motion for adjournment. Manager Brinson, second, Manager Jones, all in favor? Aye. All right, thanks. Okay, I will just note that we finished at 4:45.